and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Douglas Peterson from UConn Health, lead author on prevention and management of osteoradionecrosis in patients with head and neck cancer treated with radiation therapy, International Society of Oral Oncology, Multinational Association for Supportive Care in Cancer, American Society of Clinical Oncology Guideline. Thank you for being here, Dr. Peterson.
Thank you, Brittany. My pleasure to be here.
Then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Peterson, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the topic we're here to discuss, Dr. Peterson, could you first provide an overview of the scope and purpose of this joint ISOO-MASCC-ASCO guideline?
I'll be pleased to do so, Brittany. And again, thank you for the opportunity to represent the panel in this guideline. The panel has strived to present a guideline that brings consistency in clinical practice regarding prevention and management of osteoradionecrosis of the jaws, ORN, based on the highest quality contemporary science. Now, given the mechanistic and clinical complexity of ORN, we also stress the importance of interprofessional oncology care of these patients. The team includes, but is certainly not limited to, clinicians representing radiation oncology, head and neck surgery, medical oncology, otolaryngology, dental medicine, oral oncology, oral and maxillofacial surgery, and patient advocacy organizations. So it really is a collective enterprise that we bring to bear in the guideline. Now, in some cases, the panel has been fortunate to be able to utilize a high-quality evidence base in the literature upon which we could build strong recommendations. In selected other cases, however, we utilized informal consensus given the low evidence quality in the field. The recommendations that we've presented have been carefully framed in this context, again, with the goal of providing state-of-the-science guidelines in clinical decision-making and management of ORN. I'd also like to point out that the guideline brings linkage to other guidelines as published by ASCO and other major oncology organizations regarding management of symptoms and other supportive care needs associated with ORN. These companion guidelines include addressing pain, dysphagia, oral care, trismus, and psychosocial impact and survivorship, to name a few. I'd also like to say that combining the expertise of ISOO, MASCC, and ASCO has provided important opportunity to produce this guideline. This has been a comprehensive effort by many experts. In addition to outstanding input from the panel, I am also personally so very grateful for the expert input from ASCO's Evidence-Based Medicine Committee, as well as endorsements from other key organizations, including the American Head and Neck Society, the American Society for Radiation Oncology, and the American Academy of Oral Medicine as endorsees of the guideline. And then finally, in addition, Dr. Novosad Ismaila's leadership as ASCO staff has been absolutely invaluable as well.
Excellent. I appreciate you providing that background on the development of this evidence-based guideline, which was developed by a multi-organizational and multidisciplinary panel. So then to dive into the key recommendations of this guideline addresses 6 clinical questions. So starting with question 1, what key points would you like to highlight regarding how ORN is characterized, graded, and reported? And what is the recommended initial workup for patients?
Osteoradionecrosis of the jaw, of the mandible, and maxilla should be characterized in the view of the panel as a radiographic lytic or mixed sclerotic lesion of bone and or visibly exposed bone and or, importantly, bone probed through a periodontal pocket or fistula. And in this latter case, the clinical appearance of exposed bone may be extremely subtle. ORN is occurring within an anatomical site previously exposed to a therapeutic dose of head and neck radiation therapy. So we have a combined radiographic clinical approach characterizing the lesion in the context of the patient having received previously a therapeutic dose of head and neck radiation therapy. We do recommend that clinicians evaluate ORN based on the most contemporary staging system, the ClinRad system, which is cited in the publication itself. We also advocate for the use of the ClinRad staging system not only in clinical assessment of patients, but also in clinical trials moving forward. And we'll touch a little bit later on future research opportunities as well. And then finally, the initial evaluation of ORN should include the clinical intraoral examination. And again, the appearance of exposed bone may be extremely subtle, and or a formal radiographic examination. And the guideline delineates the various types of radiographic examinations that we recommend.
Understood. Thank you for reviewing those recommendations regarding reporting and characterization of ORN as well as workup. So then the next section of the guideline focuses on the best practices to prevent ORN of the head and neck prior to radiation therapy. What are the key recommendations of that section?
As with other adverse events in oncology patients, prevention is key. Prevention of ORN does indeed require interprofessional management. The guideline lists several key recommendations along these lines. Now, an important caveat in what the guideline presents is that the target coverage of tumor should not be compromised in order to avoid radiation dose to bone. So that's a very important caveat. Now, having said that, focused efforts should be made to reduce the mean dose to the jaw and the volume of bone receiving above 50 gray whenever possible. So it's really a balance between maximizing target coverage of the tumor while limiting exposure to normal bone. In addition, a dental assessment by a dentist and dental specialist, if possible, is strongly advised prior to therapeutic intent radiation therapy. And the purpose of this assessment by the dental team is to identify and remove teeth, which will place the patient at risk of developing ORN during the patient's lifetime, and to comprehensively educate the patient about the lifelong risk of ORN. Dental extraction in advance of radiation is often a consideration in these patients, and if clinically indicated, should occur at least 2 weeks prior to the commencement of radiation therapy. Now, having said that, in the setting of rapidly progressive tumor, extraction should be deferred and not cause delay in the initiation of radiation therapy.
So you've just touched on key points regarding prevention prior to radiation therapy. So following those recommendations, what does the expert panel recommend regarding best practices to prevent ORN after radiation therapy?
This can be a challenging clinical issue. So the panel recommends, prior to finalizing dental treatment plans that may include extractions in patients with a history of head and neck radiation therapy, a review of the radiation therapy plan should be performed with particular attention focused on dose to mandible and maxilla. For teeth in areas at high risk for ORN, alternatives to dental extraction may be possible. For example, root canal or endodontic procedure, crowns, dental restoration, or dental filling should be offered unless the patient has recurrent infections, intractable pain, or other symptoms that cannot be alleviated without extraction. So it really becomes a combined clinical decision-making effort between the dental team and the oncology team. One controversial area has been hyperbaric oxygen being administered prior to dental extractions in patients who have received head and neck radiation therapy previously. The panel does not recommend routine use of prophylactic HBO prior to dental extractions in these patients who have received prior head and neck radiation therapy. However, the evidence base here is limited with low quality, and we offer a weak strength of recommendation. It is a controversial area. So we did also include a qualifying statement that prophylactic HBO may be offered to patients undergoing invasive dental procedures at oral sites where a substantial volume of mandible and or maxilla received at least 50 gray. This is an area of controversy. We can talk about this in future research directions, but clearly new high-quality research related to the role of HBO in the management of these patients is needed.
Definitely. Thank you for touching on those points and that area of controversy as well. We can definitely touch on that a bit later as we talk about future research in this field. So then, as you mentioned, Dr. Peterson, this guideline addresses both prevention and management. So moving into the management of ORN, how should ORN be managed non-surgically?
The guideline relative to non-surgical management of ORN is focused on the use of pentoxifylline. Now, this may be used in, and this is important, in cancer-free patients with mild, moderate, and severe cases of ORN. The pentoxifylline, the guideline also notes, is most likely to have a beneficial effect if the treatment is combined with tocopherol, antibiotics, and prednisolone as well. So there's clinical judgment involved in the non-surgical management of ORN centered with pentoxifylline in combination with tocopherol, antibiotics, and prednisolone.
Understood. And then expanding on the management of ORN, what are the key points for surgical management of ORN?
The panel offered several recommendations for which the strength of the recommendations was strong. And just to cite a few, in partial thickness ORN, as defined by the ClinRAD stage 1 and 2 that we talked about earlier, surgical management can start with transoral minor interventions, which can lead to resolution over time. It may take time. It may take weeks or even a few months. Now, this minimally invasive surgery may include debridement, sequestrectomy, alveolectomy, and or soft tissue flap closure. Furthermore, small defects clinically, for example, less than 2.5 centimeters in length, may heal spontaneously with local topical measures such as we've described. It is recommended that larger defects, larger than 2.5 centimeters in general, be covered with vascularized tissue.
Appreciate you reviewing those recommendations regarding surgical management of ORN. So then to wrap up our discussion of the recommendations with the final clinical question, what is recommended for assessment and management of adverse events associated with ORN?
This is a really important area as well, in addition to prevention and management of ORN per se. The panel recommends that patients should be assessed by their healthcare providers for the presence of adverse events at the time of ORN diagnosis and periodically thereafter until the adverse event resolves based on patient status, including any interventions for the adverse event that are clinically indicated. The panel, in its literature evaluation, learned that there is a relative lack of data specifically directed to the management of adverse events associated with ORN. However, this is such an important area that we wanted to address it head on. And so the management we recommend should be informed by pertinent available other guidelines that have been developed for analogous symptoms and or disease states. The guideline provides links to these companion guidelines developed by ASCO as well as by MASCC and ISOO, the European Society of Medical Oncology, and NCCN. And so in the guideline, we provide links on management of adverse events as produced by these other organizations. Table 3 presents a summary of the guidelines that address symptoms and supportive care needs associated with ORN.
Thank you for reviewing all of these recommendations. It's clear that the panel put a lot of work and thought into these recommendations and provided needed guidance in areas with limited evidence. We'll have links available in the show notes for listeners to be able to go and read these recommendations for themselves and refer to the tables that you mentioned. So in your view, Dr. Peterson, what is the importance of this guideline and how will it impact clinicians and patients with head and neck cancer?
As we've talked about really throughout this podcast, the guideline is designed to synthesize the contemporary science regarding ORN and translate that into recommendations for clinical practice, both from prevention and management. As noted in the guideline, oncologists plus other interprofessional healthcare providers have been directly involved in the creation of the guideline, that interprofessional theme, which we believe is so essential, again, given the mechanistic and clinical complexity of ORN. Now, in addition to the expertise of the panel, the pending widespread distribution of the guideline represents an additional important opportunity for extending the impact across clinical oncology. So in addition to the publication in Journal of Clinical Oncology, dissemination by MASCC and ISOO, as well as our endorsees, the American Head and Neck Society, the American Society for Radiation Oncology, and the American Academy of Oral Medicine, will also be key in broadening the impact and hopefully the utilization of the guideline. And members of these organizations may very well be involved in the management of these patients as well. And then finally, the guideline is also designed to stimulate future research based on current gaps of the knowledge. And we've touched on some of those gaps, for example, with HBO, for which new high-quality research is needed.
Absolutely. It's great to have so many partners in this guideline, and we hope that this guideline will have a large impact for patients with head and neck cancer to improve their quality of life. So then your final comment leads nicely into my last question, in that we've already talked a little bit about some of the future research opportunities that this guideline highlights. So to wrap us up, Dr. Peterson, what are the outstanding questions regarding osteoradionecrosis of the jaw, secondary to head and neck radiation therapy in patients with cancer?
There are several key areas that the panel identified as we went through a rigorous review of the highest quality literature. Some of the key areas to address moving forward include prospective studies are needed to evaluate the clinical presentation, trajectory, and response to treatment of ORN-related symptoms and function impairment. In other words, the adverse event side of the story. In addition, social determinants of health, quality of life, and psychosocial impact of ORN warrant further investigation in head and neck cancer survivors as well. In addition, new research, including randomized controlled trials and prospective multi-center trials regarding the systemic and surgical treatment of ORN, is also warranted. And we've touched on, for example, hyperbaric oxygen. Hyperbaric oxygen has been a long-standing management strategy of ORN. However, the trials to date are of limited quality in relation to supporting its use. So high-quality new research related to the role of HBO in these patients is needed. And the expert panel also encourages creation of predictive tools, a priori tools directed to development, grading, and staging of ORN. And these can include, for example, bone turnover markers and genetic markers, to name two. And finally, the research opportunities that are presented in the guidelines, such as I've briefly summarized today, should ideally be addressed in large, prospective, multi-center observational studies of risk, outcomes, and financial cost of ORN or the various treatment strategies that are highlighted in the guideline.
Excellent. Well, we'll look forward to research that addresses those outstanding questions. And I want to thank you so much for all of your work on this guideline and for taking the time to share the highlights of this guideline with me today, Dr. Peterson.
Thank you. My privilege to do so, Brittany.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/head-neck-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.